Thank you, Dr. Matthew Fay, a GP from Bradford, Yorkshire, and trustee of the AF Association and also Arrhythmia Alliance medical advisor. Thank you for joining us to answer questions on atrial fibrillation.
Pleasure, Trudie.
Dr. Fay, we're here to talk about atrial fibrillation and anticoagulation. Can you tell me why it's so important to be prescribed anticoagulation therapy?
People who suffer from AF, the top chambers of their heart becomes very irregular in how it contracts. And this can lead to small clots being formed because the blood becomes a little bit stickier in AF. And the fact that the atria don't contract properly in AF means that small clots can form in there. And if they move from the atria through the circulation to the head, then we will end up with a stroke. Now, what we can do is we can arrange for you to be anticoagulated, affect the stickiness of the blood so that those clots don't form or are much less likely to form, and so reduce your risk of suffering a stroke due to your atrial fibrillation.
And should a person diagnosed with AF but with no other conditions under the age of 65 still be anticoagulated?
People who are under the age of 65 with no other illness are at low risk of developing an AF-related stroke. They still have a slightly higher risk than somebody else of their age and gender, but that risk is regarded as quite low. And so anticoagulation wouldn't be routinely offered. However, of course, there's always special cases, and you may find that your clinician does want you to be anticoagulated. That might only be for a short while, if the plan is to try and return the heart back to normal rhythm, where you would have to be anticoagulated for the procedure, or it may be something very specific about the shape of your heart or the nature of your family history that means that the consultant may wish you to be anticoagulated in the long term.
If I'm prescribed anticoagulation, will it take away the symptoms, the fluttering, the bag of worms in my chest that I feel with it?
Anticoagulation isn't a treatment for the symptoms of AF. Unfortunately, those symptoms require other interventions. The anticoagulation is there to reduce your risk of stroke, which it does very effectively. But no, it won't affect the symptoms that you feel.
And what is the difference? For years we've heard of warfarin, but now there are 4 DOACs, as they're referred to. What is the difference between warfarin and DOACs?
So, warfarin and the DOACs are both groups of anticoagulants. Warfarin, a very clever medication which works through the body's use of vitamin K to affect anticoagulation, has been used for many years. But because it works through an intermediary of how our body deals with vitamin K, it can be a little bit unpredictable, so affected by other medications or maybe your diet or maybe your general health. The newer group of drugs, the DOACs, which are direct oral anticoagulants, have an immediate effect on the way that the blood actually causes a clot. So they're much more predictable in the way that they work, they're much more stable, and they interact with a lot less medications. So in some respects, they're easier to use.
And my doctor swapped me from warfarin to a DOAC, but I'm really concerned because with warfarin I have regular blood checks, so I know that my INR has to be within a certain range. How do I know if a DOAC is working if I'm not receiving blood tests?
So, as I say, with the warfarin, because it works through other systems, so it doesn't directly affect your the way the blood coagulates, forms clots. It has lots of variables in how it can function, and we can change those variables even through what we eat at dinner time. And so we must monitor how it's affecting the coagulation. These new drugs, because they don't have any intermediate steps, are much more predictable. We know that they work because we have got the study evidence that shows that they work at those set doses. They don't need monitoring, which is a convenience for you as a patient, but also makes their use much easier for me as a clinician.
Now, one patient always used to take aspirin, has been told that aspirin isn't working and they should have an anticoagulant. Why is aspirin no longer recommended?
So aspirin was recommended for many years in atrial fibrillation as well as anticoagulation. However, what we have found in study evidence is that aspirin is dramatically less effective at reducing stroke in atrial fibrillation. Many would say it gives no benefit to the patient with AF compared to the patient who doesn't have AF to prevent strokes. However, it has the same risk of causing bleeding as anticoagulation. So for a much reduced benefit, you carry exactly the same risk using aspirin compared to an anticoagulant. So all doctors now would recommend an anticoagulant. And if you can't take the anticoagulant because you're worried about the bleeding, and that's what most of us are concerned about as a side effect, then aspirin isn't a substitute, because aspirin will cause the same level of bleeding as we would see with an anticoagulant.
Now, for a small minority of people, they cannot tolerate any of the oral anticoagulants. So what can they do to reduce their risk of an AF-related stroke? Is there any other alternative?
So within the atria, particularly the left atria where most of this clot forms, there's a small tail that comes off the back, a little bit like an appendix in your abdomen. And this left atrial appendage is where about 70% of the clot can form during atrial fibrillation. Now, we have the technology to put a small bung in the top of that appendage, so thus blocking the hole. So any clot that forms in there can't get into your circulation and can't cause a stroke. So these left atrial appendage occluders, as they're called, are reasonably good as warfarin at reducing AF-related strokes. But they do need a little procedure to put them in. So there is a little bit of risk as the device is inserted, and it should be inserted by a professional who's done them in the past, or has been closely supervised by somebody who has done many in the past. But they are effective, and it means that you don't require subsequent aspirin or anticoagulation if you can't tolerate those medications.
So anticoagulants or LAAOs all to help reduce the risk of AF-related stroke?
Absolutely.
Thank you.